Neurology, otology. All right, so for otology, or just kind of the study of the ear and all, I'm going to be covering all the physiology, the anatomy, and the pathology that you need to know in order to just understand the ear. Once again, it's a lower yield topic, so I'm just going to kind of cram it all in one video. I'll let you know which ones are specifically high yield that you must know, but pretty much everything else, I'm just going to run through it. So first and foremost, let's talk about the anatomy and physiology. We have the outer ear, the middle ear, and the inner ear. That's just what the ear is broken up into. The outer ear is relatively not that important. It's the pinna or the auricle, and it also contains the auditory canal with the tympanic membrane. Now, what they want you to know about the outer ear is that it's innervated by the vagus nerve. So whenever you have pain or anything like that towards the outer ear, you will have vagus nerve involvement, okay? They might ask you, a patient has like just outer ear pain, essentially, and they might ask you what nerve is involved. It's gonna be the vagus nerve. Next is the middle ear. The middle ear, what you need to know is that there's three bones that kind of make up the middle ear. They're the ossicles, the ear bones, and it's the malleus, the incus, and the stapes, okay? And it's in that order from outermost to innermost, and it makes up the inner ear. They help amplify sound so that from the tympanic membrane to the inner ear. And lastly is the inner ear. The inner ear is made up of a bunch of different structures. You have the cochlea, which is fluid-filled, and then you also have a bunch of different areas that have specialized hair cells, which help transduce sound, okay? And they transduce sound to the brainstem via the cranial nerve 8, right? So what they want you to know, first and foremost, is that different frequencies from that travel to the middle ear are kind of relayed to the brain in different standpoints or at different areas of the ear, okay? So lower frequencies are heard at the apex, okay, known as the cochlear cupola, all right? I'm bad at pronouncing things, but it's a cochlear cupola, all right, or cupola. And then higher frequencies noises are heard at the organ of Corti, okay? And once again, low frequencies heard at the apex and high frequencies heard at the base, okay? So low frequency heard at the apex, and it's going to be the cochlear cupola, and high frequency is heard at the base, and it's going to be the organ of Corti. All right. Now, next we're going to be talking about otitis externa. So we're going to be kind of getting into some pathologies. First, we have otitis externa, and this is just inflammation of the external auditory canal. Okay. And you're going to have pain. The patient's going to present with severe pain to like pulling on the pinna, okay, or the auricle, the outer ear. And it's highly associated with pseudomonas or swimmer's ear, okay? So whenever they ask you, like if they give you a patient that's presenting with otitis externa, they have inflammation of the external auditory canal, as well as, pain when moving around the auricle, then you can kind of think of pseudomonas as being the cause, okay? And pseudomonas is a modal bacteria. That's a question that they would like to ask. And so it's usually associated with water exposure as well from swimmer's ear. All right. Now, there's also another thing known as malignant necrotizing otitis externa. This is when you're going to have granulation tissue in the ear canal. Okay. And it's just invasive infection causing essentially osteomyelitis. All right. Once again, otitis externa, if you're thinking of anything, it's pain on pulling the pinna or auricle and causing inflammation of the external auditory canal. And it's highly associated with pseudomonas. All right. That's what you kind of need to know. Next is otitis media. Otitis media is a high yield topic in otology. So this is the first high yield topic we're going to really hit. Otitis media is inflammation of the middle ear, right? They named it pretty well. And you have to know that it's caused by three main agents. The first one's non-typable, which means that there's no capsule. Haemophilus influenza. So it's a Haemophilus influenza that doesn't have a capsule, and that means that there's no vaccine available for it. So it's not like the type B that has a vaccine for it that we're all protected against. No, this is the non-typable one. Since it's non-typable, that means that there's no capsule, and that means that there's no vaccine available. So it leads to an increased risk of infection. Anyone can get the infection, and it can cause otitis media. Another one is strep pneumo. You know that from the MOPS mnemonic. M is for meningitis, O is for otitis media, P and S, you know those, okay? And then the last one is Moraxella catarrhalis, the lowest yield one, but they could potentially ask a question on it. Now, this is associated with eustachian tube dysfunction, okay? And when you have a eustachian tube dysfunction, it can lead to overgrowth of bacterial colonies in the upper respiratory tract. And what the eustachian tube is, it essentially connects our middle ear to the nasopharynx, okay? And this equalizes the pressures within our ENT system, the ears, nose, and throat system, all right? Because if we had two separate systems, we would have two separate pressures affecting one another, all right? So this is very, very important because if a patient has for example, as we age, okay, our eustachian tubes start to become larger in their slope, okay? So they start to slope way more. However, when you're younger, it's more horizontal. So drainage from the middle ear to the throat is actually decreased when you're younger, right? Because it's more horizontal. As we age, that slope starts to increase and drainage becomes easier. All right. But once again, when you're younger, it's more horizontal. And so it allows for bacteria just to stay there for longer periods of time because draining doesn't really occur as easily. So that's why you'll see kids have a lot more ear infections compared to adults. All right. Now, same process in otitis media. It's usually because of eustachian tube dysfunction. All right. Now, once again, usually seen in children less than 2 years old. I gave you the 3 most common types, but what they want you to know, and this is very high yield, is that it can spread and lead to a brain abscess. Okay, so the otitis media infection can lead to brain abscess. All right, it may go to cranial nerve 7, and then which is the facial nerve, and it can also cause facial paralysis, Bell's palsy. All right, so those are the 2 high yield associations that you need to know. It can cause a brain abscess, or it can cause facial nerve palsy. All right, so keep that in the back of your mind when doing otitis media. Next is going to be talking about something that's not really, not connected or not written down per se, but it's high yield or just an associated fact that I think is important is that also in connection to the eustachian tube, remember the eustachian tube connects the middle ear to the nasopharynx. So whenever you have a cancer or carcinoma at the nasopharynx, it can lead to obstruction of the tube and lead to middle ear effusion. So if a patient has some type of nasopharynx cancer, keep in mind, they might ask you, what should you be worried about? Or what could be an associated symptom? Well, an associated symptom could lead to obstruction of the tube and middle ear effusion because of obstruction of the eustachian tube. All right. So remember that the ears, nose, and throat are kind of one whole system because of all that connection from the eustachian tube. All right. Next is common causes of hearing loss. What you need to know about this is presbycusis. Okay. They're going to ask, what is presbycusis? That's just age-related hearing loss. Okay. It's just progressive bilateral sensorineural hearing loss. And it's just due to age. And I remember a question asking, what is it similar to? And they'll ask you it being similar to age-related visual loss, okay? And we'll talk about that in the vision. But essentially, it's known as presbyopia. This one is presbycusis, which is the age-related hearing loss, okay? Now, how can you help diagnose hearing loss? The Weber test and the Rene test are 2 very important tests that you kind of need to understand because there's a lot of questions that stem from it. When you know it, though, it's so easy, okay? So what I did was that I just remembered one, and then the other one was like pretty much the opposite, okay? And that helped me a lot. So for the Weber test, what you're gonna do is you're gonna put the tuning fork on the middle part of your skull, okay? So it's like gonna be like between your eyes, but like up top on your skull, okay? Now, if you have localizing, like if you hear the noise localizing to the affected ear where you have hearing issues, okay? So like let's say a patient presents to you and they say, "Doc, I have right hearing problems," because these patients obviously are going to know what's wrong with them. They can hear things on their left side better than they can hear on their right side. So they're going to come to you and they're going to say, "Doc, I have bad hearing on the right side, I think." So you're going to do the Weber test. You put the tuning fork in the middle of their skull on top of their head. All right. And if it localizes to the affected ear or the right ear, that means that it's conductive hearing loss. Okay. It's a conductive hearing loss. And conductive hearing loss just essentially means that there's something within the ear. It could be like wax that could be blocking it. It could be a problem with the ossicles, right? It's just something within the ear that's essentially blocking conduction, all right? Now, for the Weber test, if it localizes to the unaffected ear, so within our patient, if it localizes to the left side and he says, "Hey, Doc, I hear the vibration more on the left side, the unaffected ear," then you know that you have a total sensory neural hearing loss, not a conductive hearing loss. And sensory neural hearing loss involves the cranial nerve 8 and those hair cells, okay? So once again, I just remembered one of them, all right? And so for the Weber test, you have conductive hearing loss if it localizes to the affected ear. If you hear the noise louder in the affected ear, then it's conductive, all right? And that's the Weber test, all right? Now, for the Rene test, it's going to be, if you hear, what you're going to do is you're going to do the tuning fork and you're just going to place it near the outside of the ear, and then you're also going to place it on the back of the ear, okay? So what happens is that you have conductive hearing loss if the bone conduction, so when you place it on the back of the ear, is greater than the air conduction, okay? Does that make sense? So the air conduction is when I put it just right out front in front of the ear, and the bone conduction is when I place it right on the back of the ear, actually touching the person. All right. So you have conductive hearing loss if you have bone conduction sounding greater than air conduction. And it's going to be vice versa for sensory neural loss. You have air conduction better or heard louder than bone conduction and sensory neural hearing loss in the Rene test. So once again, I only remember the conductive part. And that's going to be helpful for the Rene test is that you have a louder bone conduction. So the way that I remember these is that whack and bark. So for the Weber test, the affected ear is going to lead to conductive. So if you hear affected ear, it's going to cause conductive hearing loss. So WAC, whack. So Weber test localizes to the affected ear, then it's going to be conductive. All right. Now, Rene test, it's going to be bark. Okay. So B is for bone conduction. A is for air conduction. Okay. So B is before A in bark. So BARC. So B is greater than A. So bone is greater than air. And then the RC is for Rene. And then the C is for conductive. Okay. So bone is greater than air in the Rene test tells you that it's conductive hearing loss. All right. So that's how I remember the diagnostic hearing loss tests. All right. Now, next is going to be cholesteatoma. Cholesteatoma is abnormal growth of keratinized squamous epithelium in the middle ear. Okay. If you ever see someone talking about collections of squamous cell debris, they're talking about cholesteatoma. It's like that straightforward. Or if they say skin is in the wrong place, I don't know. I don't remember really seeing that many skin in the wrong place. I remember them saying collections of squamous cell debris or collection of debris in the middle ear. Okay, they're talking about cholesteatoma. All right. Now, other things you'll see with it is painless otorrhea. All right, with conductive hearing loss, and at times you're going to see a pearly mass. All right, pearly mass behind the tympanic membrane. All in all, with all that put together, that's cholesteatoma. So whenever I would see like painless otorrhea, that was a huge trigger to me. Painless otorrhea. All right. So that means just painless, like oozing of substance out of the ear. All right. Oozing of liquid out of the ear. It's painless otorrhea with conductive hearing loss and a pearly mass behind the tympanic membrane with collections of squamous cell debris found in the middle ear on examination. All right. That's cholesteatoma. That's going to get you every single question on this. Okay. Now, lastly, another high yield thing is vertigo. So I've covered now 3 high yield things: vertigo, the hearing loss diagnostic testing, Weber and Rene, and otitis media. So those are your 3 high yield things you need to know. Vertigo, it's going to be separated, okay? Now, what you need to know is you have peripheral vertigo versus central vertigo, okay? What I care mainly about is peripheral vertigo, okay? And we're going to kind of talk about the different types of peripheral vertigo. The first one I'm going to start is benign paroxysmal positional vertigo, and it's called BPPV, right? BPPV, all right, is vertigo due to semicircular canal debris. That's the first question. Boom. I'm giving you a question right off rip. Boom. Okay. It's due to semicircular canal debris. BPPV is due to semicircular canal debris. All right. Now, how do you know like it's BPPV compared to other peripheral vertigos? Okay. Well, the way you know it is because 1, it lasts less than 1 minute. So the patient will only have vertigo symptoms lasting less than 1 minute. Okay. Number 2, it's triggered by head positional change. Okay. Very important. Those 2 things are going to help you differentiate BPPV from Meniere's disease. All right. Which is the other peripheral vertigo that you have to know. Meniere's disease is going to have 1, vertigo that lasts 20 minutes to 24 hours. So it's much longer vertigo. If you see much longer vertigo lasting for that long, it's Meniere's disease. Okay. It's also associated with sensorineural hearing loss, as well as tinnitus, which is just like ringing in the ears, okay? Now, this is caused by increased endolymph, which is just increased fluid within the semicircular canals, okay? So very, very important, those differentiators, okay? Because they love to test on what's BPPV versus what's Meniere's disease. So let's run it through real quick one more time. BPPV is brief vertigo symptoms, less than 1 minute, triggered by head positional change, and it's caused by semicircular canal debris. On the other hand, you have Meniere's disease, which is vertigo that lasts from 20 minutes to anywhere to 24 hours. It causes hearing loss, sensorineural hearing loss, and tinnitus. And it's due to the fact that you have increased endolymph. All right? And all of this, right, is just vertigo. And vertigo is just the sensation of excessive motion due to vestibular dysfunction. Okay? That's kind of the overarching definition of what vertigo is. All right? So if you know that, you should be good on otology.